Prosthetic joint infection presentation. Patients may have a history of recent or active bacteremia, multiple local surgeries, or skin or epithelial tissue penetration, for example intravenous drug use, colonoscopy, dental work, ulceration, or wound complications. Symptoms of PJI. Common symptoms include persistent pain and stiffness at the site of the arthroplasty, which is present in over 90% of infected patients. Acute infections often present with swelling, tenderness, and drainage, while chronic infections show more subtle symptoms, with pain worsening over time and function deteriorating. Physical examination. On inspection, a sinus tract to the joint is a definitive sign of infection. Other signs include warmth, redness, and swelling, along with a low-grade fever. Motion is often limited by pain and swelling. Imaging in PJI. Radiographs. Radiographs can reveal periosteal reactions, scattered patches of osteolysis, generalized bone resorption without implant wear, transcortical sinus tracts, and implant loosening. Bone scan. A technetium-99m bone scan detects inflammation, while indium-111 scans detect leukocytes. A triple scan can differentiate infection from fracture or bone remodeling. While bone scans have 99% sensitivity, their specificity is lower, ranging between 30% and 40%. Positron emission tomography. PET scans may help identify areas of high metabolic activity using fluorinated glucose. These scans offer 98% sensitivity and 98% specificity. MSIS criteria. The Musculoskeletal Infection Society, MSIS, provides criteria for diagnosing prosthetic joint infections. Major criteria include the presence of a sinus tract communicating with the prosthesis or isolation of a pathogen from two separate tissue samples from the affected joint. Minor criteria, including elevated ESR, CRP, synovial WBC, and PMN levels, as well as purulence in the affected joint, are considered if at least 4 of 6 are present. Studies in PJI. Blood panels, including WBC count, are not highly specific or sensitive for prosthetic joint infections. However, inflammatory markers like CRP and ESR can be useful. CRP peaks 2 to 3 days after surgery and returns to normal after 3 weeks, while ESR peaks 5 to 7 days after surgery and normalizes within 3 months. Joint aspiration. Joint aspiration is indicated when infection is strongly suspected. The analysis includes cell count and differential, gram stain, and cultures. Elevated synovial WBC and PMN levels are suggestive of infection. Perioperative analysis. Microbiological tests and histology help confirm the diagnosis. Repeat aspirations or intraoperative specimens are used to identify the same organism. In equivocal cases, intraoperative frozen sections can help confirm infection.